Thank you so much, and thank you so much for, I need to be a little bit tippy-toe, I think. And thank you so much for allowing me to be here. And thank you, Dr. Rosen, Dr. Rose, for the kind invitation, and the NCAN family for allowing me to talk to you about the hormonal basis of neuroendocrine tumors. For those who don't know, besides a medical oncologist, I'm also an endocrinologist. So hormones is one of my passions too, and understanding as well the hormonal basis, and understand also how these excess of hormones can affect the life of patients and the quality of life of patients. As you learned earlier, neuroendocrine tumors can be anywhere in the body. Any cell in the body can be affected by the neuroendocrine tumor. But another important aspect of these neuroendocrine tumors is that they have the capacity to produce hormones. Depending on where the neuroendocrine tumor is located, they can also produce a very specific hormone, and depending on what hormone the neuroendocrine tumor produce, they can have a very specific, clinical manifestation. Oops, sorry. I'm a little too short, sorry. Thank you. You can help. I think the phone is perfect. Okay, that's good. That's better. Yeah, I'm 5'1", so you can see I'm very tiny. So we're going to discuss a little bit more in details about these different sex hormones and what symptoms may produce and how we can treat as well. But for the purpose of our talk today, we're mainly going to focus on the excess of hormones related to the small bowel neuroendocrine tumors, as well as we'll discuss a little bit of the pancreas. There is another type of neuroendocrine tumors called pheochromocytomas and paragangliomas. We're not going to talk about that today, but depending on these tumors also have the capacity to produce hormones, and based on the hormones, they can also have a very specific clinical manifestations. So in terms of the small bowel neuroendocrine tumors, more than 90% of patients with carcinoid syndrome involve the liver, with primary tumors in the distal small intestine or proximal colon, as you have heard earlier for our esteemed speaker, Dr. Rose, Dr. Gupta, as well as Dr. Malushu, about the different locations of neuroendocrine tumors, and as well as what is the clinical implications and when surgery may be indicated. But let's talk a little bit about what the pathway of serotonin, because a lot of you have heard about that small bowel neuroendocrine tumors can produce this excess of hormone, and this excess of hormone is called serotonin. But let's just talk a little bit of what exactly is and how that causes the symptoms. Tryptophan is an essential amino acid. So tryptophan, it can be acquired for many of the things that we eat. When we ingest tryptophan, then it goes and metabolized in the intestine, so we can see here, and we kind of like look like a very small portion of the small intestines, we can see it here in the picture, and we look into the microscope. The small intestine has these very crepes, they call it like crepes, and tryptophan, in those crepes, tryptophan is that metabolized to serotonin. There is an enzyme that helps the conversion of tryptophan to serotonin, and that's called an enzyme tryptophan hydroxylase. And that's an important hormone to know, because there is a medication that inhibits that enzyme. Once tryptophan is converted to serotonin, then serotonin, goes into the liver, and then in the liver, then metabolized to this test that we're all familiar with, which is called 5-HIAA, which we can test it in the urine as well as in the blood. Now, what are the effects of elevated serotonin? It can cause the carcinoid syndrome, and it can also cause the excess serotonin. It can be also responsible for as well of the tumor growth. And the importance of controlling the excess of hormones is relatively important, just because it can also helps control the symptoms, as well as help have control of the tumor growth. And this is just a different pictured of how tryptophan is then converted into serotonin by, remember, the little crepes that are neuroendocrine tumor cells in the small intestine, and then after that into the liver is that converted into the 5-HIAA, and that's the one that we measure in the urine or in blood. Now, tryptophan, as I mentioned, is an essential amino acid, and it has different functions, like many of the amino acids in our body has different functions as well, but some of the functions is the maintenance of some of the body proteins, as well as muscles and certain enzymes, as well as certain function of the neurotransmitters. But when there are these excess of serotonin, like I mentioned, they're going to have very specific symptoms, and as well as complications if we don't treat it properly. Now, what are the symptoms of carcinoid syndrome? So as you know, there is many symptoms related to carcinoid syndrome. The most common is diarrhea. Diarrhea related to carcinoid syndrome can be quite debilitating, but this excess of hormones can also cause other complications. It can accumulate in the heart valve, and it can cause scar tissue, the heart valve, and in those situations, there is a condition called carcinoid heart disease as a result of this excess of hormone. It can also cause other symptoms like flushings as well. It can also cause wheezing and cough and a series of symptoms related to the excess of serotonin. I'm sure you have heard about the 5 E's, and what is mean the 5 E's is the first letter of epinephrine, eating, emotions, ethanol, and exercise. And these are the ones that a lot of patients are familiar with because there is depending on where the patient the patient has different experience related to these different situations, they can have these exacerbated symptoms. For example, eating is one of them. There are certain foods that has the high content of tryptophan. That said, it doesn't mean that because we're seeing these different foods that you need to stop eating those. That's not what usually we recommend. Usually patients may have different symptoms depending on the things that they do that may exacerbate those symptoms, and that's something that you need to be mindful of. Like, for example, alcohol, sometimes it can exacerbate the flushing as well. I have a patient too that, likes her glass of wine, and that's okay. So, and it noticed that whenever she was drinking a glass of wine, that the flushing was quite exacerbating. So in those situations, sometimes given a short-acting octreotide, I'm sure you have learned about the long-acting, short-acting octreotide can help minimize some of those symptoms. So as I say earlier, it doesn't mean that because these foods are suggested here that you need to stop eating those. I think it's very important that you acknowledge what may exacerbate some of the symptoms. Sometimes excessive exercise can do that, but that said, we still recommend patients to be very active. And this it doesn't happen to everyone, but if that's the case, there should be certain measurements so that way you can still do the things that you enjoy in life. And that's the reason why us as physicians and understanding this part, we can make certain recommendations to minimize as well some of the symptoms related to hormone excess. As I mentioned earlier, so these are the frequency of carcinoid syndromes, and the ones that has been reported is flushing and diarrhea. As I mentioned, the excess of hormones can accumulate in the heart valve, and they can cause what we call carcinoid heart disease, but there's a series of symptoms associated to the hormone excess. The diarrhea and the flushing, those are the most common that can be quite debilitating for patients, and that's where, there are now different interventions needed in order to control the symptoms related to hormone excess. Carcinoid syndrome diarrhea occurs in up to 80% of patients, and as I mentioned, the most debilitating component of the symptoms. Stools may vary from very few to more than 30 per day. They're typically watery, they're non-bloody, sometimes can be explosive, it can cause abdominal pain. The abdominal pain may be sometimes a consequence of what's the condition called mesenteric fibrosis, and maybe you heard that before, but we can touch base a little bit about that, or sometimes they can cause due to the intestinal blockage from the primary tumor. And diarrhea sometimes is unrelated to the flushing episode. Some patients may have more flushing than diarrhea, some patients may have more diarrhea and then flushes. So it is unrelated how the symptoms, one versus the other. So, and how do we help control some of the symptoms related to hormone excess? So, about this drug called somatostatin agonist. We have long-acting somatostatin agonists, either lanreotide or octreotide. They are monthly injections. Octreotide is given intramuscularly, lanreotide is given sub-Q. They're overall given every 4 weeks. Sometimes if the patient that is on lanreotide, sometimes they may feel like during the 3rd week, sometimes they feel like maybe the symptoms start to get a little bit worse, and in those situations, sometimes it's an indication to give it every 3 weeks instead of every 4 weeks. Octreotide, there are different doses as well. We usually start with 30 milligrams of octreotide, which is usually 1 injection, but anything about 30, like 40, 50, 60, that's usually 2 injections of octreotide. And they're intramuscular, but there is room in some occasions to adjust the dose if needed. There are also the short-acting octreotide as well. So we call those rescue shots, and it's usually in those situations of patients that have severe flushings that sometimes that can help. The goal of these drugs, it has 2 functions, and I always explain that to my patients. There is the 2 functions related of the use of this medication. It can help control the growth related to the neuroendocrine tumor, but it can also help control the symptoms related to hormone excess. So it has 2 functions. Some of the questions that I get as well is like, for example, when they're on scans, there is some growth of the tumors. The question is, do I still continue these injections? And usually the recommendation is to continue the injections as long as the tumor is functional, meaning that it's producing excess of hormones, like in this situation, like the small bowel neuroendocrine tumors or other symptoms or syndromes related to hormone excess. There is another medication that can help control these symptoms of diarrhea. The name of the medication is called telotrestat. Telotrestat is, as I mentioned earlier, there is an enzyme that converts tryptophan to serotonin, so that telotrestat inhibits that enzyme. And with that, it can also lower the levels of the 5-HIAA, but it has been proven that it can also help to minimize the number of bowel movements per day. And this is just a picture of tell you where this medication blocks, and is the blocking of the conversion of, like I say, of tryptophan to serotonin. So this is kind of like just a little bit of where this comes from. Telotrestat was approved, is approved for carcinoid syndrome diarrhea. That's the only indication that has been approved. If patient has no control of the diarrhea with the somatostatin agonist, this will be an indication to provide telotrestat. I know that sometimes insurance may have some difficulty in proving it, but as long as we make a good argument of the symptoms related to the excess of serotonin, it should be something that is not going to be that difficult to obtain. But just to show the graph a little bit, so this is kind of like the graph. So the more negative the number, that means the less the levels of the 5-HIAA. So basically, these are how the patients that were on this study, we can see that, how the levels of 5-HIAA decrease. So, and these are the levels. So we saw that these medications decrease the levels of the 5-HIAA, but also patients that had received this drug, it also was reported that the number of bowel movements per day also decreased compared to patients that did not get this medication. And that's the reason why telotrestat, again, was approved for the for carcinoid syndrome diarrhea. Now, there is a new medication. It's called paltusotine. So paltusotine is very similar to, in terms of mechanism of actions of the lanreotide and octreotide, meaning it's a somatostatin agonist, and this medication has an effect on blocking the hormone production. But paltusotine is an oral medication. So we discussed about the lanreotide and octreotide, those are injections, but paltusotine is an oral medication. So paltusotine right now is on clinical studies, but it's a drug that we hope that can be available for patients relatively soon. They are now doing this study that can lead to the approval of these medications, and paltusotine has been proven also to decrease the reduction of bowel movements per day as well as flushings. Patients that had been enrolled in the clinical study with this drug, it seems that has been effective, so something to look forward. Hopefully this drug will be available for all patients soon. Another symptom related to excess serotonin is niacin deficiency. The name of the conditions, medical name for this condition is called pellagra. And why niacin deficiency is happening. When I told you earlier, remember that tryptophan is converted to serotonin, but when there is a neuroendocrine tumor, all tryptophan goes and is converted to serotonin. So there is less availability to have vitamin B3 available. So that's kind of what happened with the neuroendocrine tumors. In the neuroendocrine tumors, by utilizing all the tryptophan to be converted to serotonin, then it's less availability to produce vitamin B3. And because of that, that can happen in some patients. It doesn't happen to everyone. Now we see it less and less because of the use of lanreotide and octreotide. So those drugs, by blocking the enzyme, the effect of the hormone excess, we see less niacin deficiency, but that has been a condition reported as well. Niacin deficiency or pellagra is a condition that is characterized by dermatitis, diarrhea, as well as dementia in some cases. So is how often it happens in patients with neuroendocrine tumors, we don't know. But like I say, it's a lot less than what it was in the past because of the use of the drugs that I just mentioned about. And that's what this slide is telling you as well. So if that were to happen, if a patient has this condition called pellagra, so there is treatment for that. And the treatment is given what is missing, which is vitamin B3. Then the treatment that is available is nicotinamide. This is something that can be even off-label sometimes in pharmacies. And that can help also help with the treatment of niacin deficiency if that were to happen. One thing about niacinamide is that it doesn't cause as much flushing as other, because sometimes when you give vitamin B3, sometimes that can exacerbate the flushing, but this agent, this niacinamide or nicotinamide, seems to not have as much as flushing compared to the other forms of vitamin B3 replacement. Another complication of excess serotonin or excess hormone is carcinoid heart disease. And it can happen in about half of patients that has with Cushing's syndrome and is related to this excess of hormones and even other hormones as well happening at the level of the heart. And it has been related that, the higher the VIH-IAA in the urine, the higher the likelihood that a patient may develop carcinoid heart disease. And that's the reason why it's very important to measure those hormones as well. How often do we check that? I usually check with each scans whenever a patient is undergoing imaging studies to see how things are going on. I usually check VIH-IAA if the levels are elevated or going like twice the upper limit of normal, even though there is really no any guidelines that tell me, well, if this is this level, you have to start screening for carcinoid heart disease. But usually when I start seeing the levels at least twice upper limit of normal, that's when I start sending the patients to see a cardiologist, so that way they can have an echocardiogram and monitor for carcinoid heart disease. There is a thought that maybe the lotristat can help with that as well, to minimize some of the symptoms or prevent or delay carcinoid heart disease. But that's there's still a research questions that is ongoing. MD Anderson has a study of the lotristat for patients that had maybe a risk for carcinoid heart disease, but it's still a question that we're still waiting to be answered. And here in these pictures, you can see that the liver, when the metastasis in the liver, that's going to produce this excess of serotonin, and it can still go to the right side of the heart, because the liver is on the right side, it goes to the right side of the heart, affect that more commonly, and it's the scar tissue that form that. It can cause deficiency of the function of the valve, as well as carcinoid heart disease, and sometimes it can worsen that to more of developing congestive heart failure and the heart not being able to pump the blood needed for the system. So I think that's something that needs to be in mind in every patient that has a small bowel, a neuroendocrine tumor, and have the follow-up needed as well with the cardiologist to do it echocardiogram. How often is the echocardiogram is recommended? So it's Depends. Some physicians may say it's every 6 to 12 months. I will say every 1 to 2 years, depending on if it's detected. That usually the cardiologist who makes the recommendation how often an echocardiogram can be done. And an echocardiogram is like an ultrasound of the heart, just to determine what is the function of the heart. And the cardiologists usually help us to determine how often. But overall, I would say once a year or every 2 years should be indicated to obtain an echocardiogram. And like I say, this is something that's the 24-hour urine. There is a blood test for 5-HIAA. It's easier, but it's not widely available in all centers. But that can also be obtained as well every time. I do it every time scans are done as well. I know sometimes it's difficult to collect the 24-hour urine collection, but now with the blood, I think it will be a little bit easier. It's something to find where is the latest center that you can obtain if a blood 5-HIAA. There is another protein that is also measured in patients that may be at risk for carcinoma heart disease, and that's called the plasma or the pro-brain natriuretic peptide, which that's a protein that is pretty much specific for the heart, produced by the heart. Sometimes that can also be a blood test that is measured in patients with small bowel neuroendocrine tumors with excess of hormones with the risk to develop carcinoma heart disease. And then the other aspect of excess serotonin is mesenteric fibrosis too. This is a clinical presentation as well of serotonin excess, and it can also be localized. This mesenteric fibrosis is localized usually where the tumor used to be located, and there is also lymph nodes that can be present in the abdomen. Dr. Maluccio, Dr. Rosent had discussed more about maybe this condition and how they can affect. I think the complications with mesenteric fibrosis is because this excess of hormones can also cause changes around the tumor and surrounding the tumor, and it's usually scar tissue that is formed. That's kind of like how I describe it, and because of that, that can place a patient at risk to develop obstruction, and sometimes the surgical intervention may be needed in those situations as well. We discussed the different clinical conditions related to excess of serotonin. So we discussed that this excess of serotonin can place a patient at risk to develop carcinoma heart disease, also a condition called pellagra or vitamin B3 deficiency. As I say, does not happen very often. We discussed about diarrhea and some patients, depending on if they have certain procedures, they may be at risk to develop carcinoma crisis. And also we discussed about mesenteric fibrosis and carcinoma heart disease. So as you can see, excess of serotonin, excess of hormone is something that we need to monitor and we need to control to avoid these future complications. And this is just describing that there's different ways to target serotonin. One is by giving the monthly injections. We discussed somatostatin agonists such as lanreotide, octreotide. We also discussed about the telotristat. That's another medication that helps as well, targets the excess of serotonin. And the newer ones that we discussed is called paltusotine. Again, that's in clinical studies, and hopefully it will be approved and available to patients first. But the goal in patients that have small bowel neuroendocrine tumors, excess serotonin, is to be able to control the excess of hormones to prevent not only the symptoms, but as well as future complications, as we discussed. And this is just to describe that serotonin is the driver of serotonin excess is a driver of carcinoid syndrome, and it plays a role in the development of the carcinoma heart disease, mesenteric fibrosis, as well this affecting the heart as well, the heart valve. It can also affect the pulmonary function as well, and this condition called pulmonary artery hypertension, and serotonin has known to demonstrate effects on tumor growth, and is important to control the excess of serotonin, as we discussed. Now, I'm going to discuss briefly about pancreas neuroendocrine tumors. Up to 30% of pancreas neuroendocrine tumors may produce hormones, and as I discussed earlier, depending on what hormones the pancreas neuroendocrine tumors may produce, then we are going to have very specific symptomatology. And it's also important to recognize because sometimes, but to address the symptomatology, there are different measurements as well, different medications that may be needed in order to address that. And these are the different pancreas neuroendocrine tumors that may produce hormone. We'll discuss a little bit of one by one, or at least the most common of the ones that we have seen, even though this is very rare. Most of the time, the pancreas neuroendocrine tumors is non-functional. When I say non-functional, meaning that it doesn't produce excess of hormones. Functional, meaning symptoms related to hormone excess. That's what we have seen for pancreas neuroendocrine tumors. When it happened, depending on what hormones the pancreas neuroendocrine tumor produced, then we have very specific symptoms. Like, for example, insulinoma, there is a pancreas neuroendocrine tumors that secretes excess of insulin, and this excess of insulin can lower the blood glucose, and that's the function of insulin. Whenever we eat, then your pancreas will release insulin in order to lower the blood glucose. But when we have too much insulin, and that's produced by the neuroendocrine tumors, the most common symptoms that we're going to see is symptoms related to low blood glucose. Gastrinoma is another type of neuroendocrine tumor. So gastrinoma, or excess of gastrin is responsible for the stimulation of acid in the stomach. If there is a lot of gastrin, there's going to be a lot of acid in the stomach. And because of that, that can also produce ulcers and even sometimes bleeding. They can have perforation because of this excess of acid in the stomach. Again, this is very rare. We can see the incidence is not very common. So there is another condition called VIP-oma. So the hormone is VIP, which stands for vasoactive intestinal polypeptide, and that hormones regulate a lot of the electrolytes in the body, and when there is this excess of VIP, certainly the diarrhea can be quite profound. They lose a lot of electrolytes as well. So we'll discuss a little bit about that. The other ones are very rare, like the glucagon. The function of glucagon is to regulate the glucose in the body, but if there is a lot of glucagon, then they can cause diabetes. Sometimes glucagon is responsible also to metabolize some of the amino acids needed in the body, what we call essential amino acids. And when there is too much of this, then it's going to cause a lot of very specific rash or erythema as well. And somatostatin is also regulates the blood glucose in the body. And when there is too much of this hormone, that can also cause diabetes too. And as I mentioned earlier, it's important to, when a patient is diagnosed with neuroendocrine tumor, it's important to recognize which one are the functional tumors and which one are and what hormone and excess is produced, because we need to have control of both. We need to have control of the symptoms related to hormone excess, but also control of the growth of tumors as well. Insulinoma, as we discussed, insulinoma is an excess of insulin, and insulin is a hormone that regulate the glucose in your body. It lowers the glucose in the body. When a patient has too much insulin, these patients will have low blood glucose. Usually the glucose is below 50. They become quite symptomatic from this low blood glucose. As we can see here, the symptoms can vary from feeling shaky or dizzy or sweaty or anxious or feeling very hungry, having headache, being very irritable, and that is released with eating something that is high in glucose, like an ice cream or something that's very high in glucose. That's kind of how it releases and how we recognize that this could be an insulin producing tumor. Most of the time, because they're so symptomatic, these patients, even with a small tumor, they're localized and is resected. Sometimes you may ask, there is a question that you'll sometimes get from patients that, if the pancreas neuroendocrine tumors is less than certain size, usually less than 2 centimeters, they usually monitor, but in a functional pancreas, you have to resect it independently of the size because the patients can be quite symptomatic. So gastrinoma is, as I say, is an endocrine tumor that produces excess of gastrin, and this excess of gastrin stimulates the cells in the stomach that produce excess of acid, and that can cause a series of symptoms such as diarrhea, heartburn, weight loss. This excess of gastrin can also cause, these ulcers can perforate because of the excess of this hormone. And the way to treat it is by giving an anti-acid medicine, and it's usually high doses of anti-acid medicine. We call these proton pump inhibitors, such as omeprazole or pantoprazole. So usually twice a day, that's what is needed in order to control the symptoms related to gastric excess. Management, it depends if it's localized. Usually surgery is indicated, but if it's more advanced or if it's progressed in other parts of the body, then are different measurements to treat the neuroendocrine tumor. We discussed about this one. We discussed about VIP-OMA. So VIP-OMA is the enzyme, let's say VIP is for vasoactive intestinal polypeptide, regulates electrolytes in the body, and when patient has excess of these hormones, they lose a lot of electrolytes, and they can cause very low potassium, very low chloride, and they can have profound diarrhea, even a lot more than patients that have small bowel neuroendocrine tumors. There are certain measurements to control as well some of the symptoms related to hormone excess. At the same time, the end goal is to be able to determine whether the tumor is localized, so they can do surgery, but if it's in places in the body, that's when different therapies will be indicated, and you will hear more about the different systemic therapies for neuroendocrine tumors. This is another condition that I feel like sometimes is not recognized. It happened a lot with lung neuroendocrine tumors, but it can also happen with pancreas neuroendocrine tumors, where it can produce excess of a hormone that causes excess of cortisol. So the hormone, these tumors can produce this hormone called ACTH. It's a long name. It's called adrenocorticotropic hormone. So just ACTH. And this ACTH hormone is responsible to stimulate the production of cortisol in the adrenal gland. So the adrenal gland is on top of the kidneys. It has, if you cut it in half, it has two layers, as we can see here, and the outer part of the layers is responsible for production of cortisol. Cortisol is needed. It's a hormone that is needed for your flight and fight response. But sometimes when there is a tumor that is producing this excess of this a hormone, which is called ACTH, this then is going to stimulate the adrenal gland to produce a lot of cortisols. And in those situations, it can cause a condition called Cushing's syndrome. Cushing's syndrome has a series of symptoms. The most common symptoms is an increase on abdominal fat. It can also has an increased abdominal fat on the neck area. It can also have like brown faces, red face as well. It can also cause muscle weakness. Sometimes it's very difficult for patients to be mobile because of that. It can cause what we call this purple striate. This excess of hormone can also cause high blood pressure, high glucose. So there's a lot of conditions that can happen with this cortisol excess. And when this happens, there are different ways to control the excess of cortisol. There are different medications to control the excess of cortisol. But sometimes in patients where we need to have some control of the tumor, especially when there is neuroendocrine tumors in different places of the body, or widespread disease, or what we call metastatic disease. Sometimes in those situations, we need to remove the adrenal gland, because by removing the stimulus, the hormone cannot do anything in terms of producing excess of cortisol, because you're removing the adrenal gland. So in those situations, sometimes it may be indicated as well. When that happens and we have control of the cortisol, then it's easier to give other systemic therapies, chemotherapies, and so forth that may be needed. So this is a summary, a slides of the different hormones that the neuroendocrine tumor may produce, and based on the hormones that the neuroendocrine tumor produce, there are different measurements that is needed in order to control the hormone excess. Some of them are very rare, like VIP-OMA, glucagonoma, somatostatinoma is super rare. Like I say, for pancreas, neuroendocrine tumors, most of the time is non-functional, but sometimes if it happens, then we need to recognize and then address the symptoms accordingly. And this is one of my last slides. You went throughout the day that the treatment of neuroendocrine tumors is personalized from patient to patient. It's not like one size fits all. There's different clinical characteristics that we need to take into account whenever we make the recommendations for the neuroendocrine tumor. We need to understand where the primary tumor is located, whether it's pancreas, lungs, whether it's small bowel. We need to understand if the tumor is in the liver only or outside the liver. We need to understand whether the tumor expresses somatostatin receptor, as you have heard earlier, in order to determine whether the patient may be eligible for this type of radioligand therapy called 177 lutetium dotatate or Lutathera or PRRT. There are different names for that. We also need to understand whether the tumor is slow growing or rapidly growing, because there may be different interventions. We need to understand also whether if it's only in the liver, what indications can be in the liver. As Dr. Malucho explained, the different type of liver-directed therapies, that may be an indication if we only see neuroendocrine tumors in the liver. We also need to understand if the tumor produces hormones or not, because as I mentioned earlier, depending on what hormones the neuroendocrine tumor produce, there may be different indications in terms of adding therapies for that. And as discussed earlier as well, neuroendocrine tumors need to be discussed with the multidisciplinary team to provide all the options available and then provide what makes sense to the patient. But again, it's not a one-size-fits-all. The treatment is personalized from patient to patient. And what I recommend to one patient, it doesn't mean that may be the same for another one, even having the same tumor type that some of our patients have. And this is a different systemic options for neuroendocrine tumors. You heard a lot about surgery today. You heard a lot about liver-directed therapies, embolization, ablation. You will learn more today about the PRRT with Lutathera and other systemic therapies. And also we discussed about the injections, the monthly injections such as octreotide and lanreotide, and also when it's indicated. This is my last slide, my summary slides, that 10 to 30% of pancreas neuroendocrine tumors may produce hormones and resulting in very specific syndromes. Small bowel neuroendocrine tumors produces a syndrome called carcinoid syndrome. Bronchial or thymic neuroendocrine tumors may produce this condition called Cushing's syndrome. We discussed this excess of cortisol. We didn't talk about paraphios this time, but this is another type of neuroendocrine tumors. There are different treatments for that. But then biochemical assessment needs to be also tested, and symptoms are quite specific. Whenever the patient produces excess of hormones, it's quite specific as well. So in those situations, we need to monitor the hormone levels. That's what I mean by biochemical assessments. Surgery is the cornerstone treatment when it's localized, and even in some patients with metastatic disease, meaning when there is more widespread, surgery can sometimes be indicated as well. It can help resect the clock, what we say resect the clock in some of the patients, but again, that's something that needs to be discussed with expert. We have Dr. Rose here, and then we have also Dr. Malucho, who are net surgeons experts, and they can certainly provide a lot of indications on when surgery is indicated. And there are different measurements needed in order to control the hormone excess, depending on what neuroendocrine tumor is or what hormone is produced. Then we need to have different measurements. And in patients with advanced or more widespread disease, there are also different measurements and treatments needed. We have treatment options, not like it was like 30 years ago where we didn't have that many treatment options. Now we have some treatment options, but also understanding, the timing and what is recommended. That's also important to understand. And with that, I would like to thank you for your attention.